Of this project.
Yeah, after the very exciting discussion in the last session, I feel a little bit like Debbie Downer coming up here and talking about some practical realities I think we need to be addressing as we go forward. And at least hopefully these will stimulate some discussion about how we think about this. So I want to say this is a session on electronic health records and precision medicine. And I want to raise a couple of issues to think about what the role of electronic health records are in precision medicine initiatives. So much of the activities that we've talked about in the last day and a half have really focused on sort of the discovery side and facilitating discovery. And obviously, a main goal of a 1 million-person cohort is to actually facilitate discovery. But in the examples that President Obama gave at the start of this, and in the example that Francis gave in his opening remarks yesterday, what we see is that there's a second piece to this that I think the public will demand in order for us to be successful, and that's an implementation piece. How do we actually bring this to participants, to the public at large, so that they see the benefit of creating this 1 million-person cohort? And so implementation is something that we've not talked very much about. But I think we need to make sure that we address implementation as we think about what the cohort looks like and as we think about what the requirements really are for our activities going forward. I also want to emphasize something that Dan Mesa said yesterday, and that is we need to think about electronic health records writ large, not in sort of a very focused sense about electronic health records as a place where providers enter data about a participant, but rather think about electronic health records in a much broader sense. Think about them as an opportunity to collect patient and participant entered information. At our place at Northwestern, we've implemented the Promise Toolkit that's been mentioned a few times here, actually in our patient portal, so that we can go in real time and collect patient quality of life information. And that's a really valuable activity that I think helps inform and improves the quality of the data that's present in, and that information goes into the electronic health record. Another thing that we've used our electronic health record for, and I think is used fairly broadly, is actually to provide research activities and research results back to participants. So we have a portal called My Research Chart, which actually provides back to the participants research data for consented projects that they've actually been involved in. And that means that they actually may see that data at the same time that their physician does. And I think that resonates very nicely with some of the discussions that we heard yesterday. So I want to make sure that we always are thinking during the course of the next hour and a half or whatever we're going to be talking about this topic, that we're thinking about electronic health records broadly. Although it goes without saying, I'm going to say it, just because we're talking about electronic health records doesn't mean that electronic health records are going to be adequate alone. They're a piece of the data set that we need, but they're also a piece of the data set that actually allows that implementation piece going forward. So we'll come back to that at some point in the future. I also need to say, and you'll hear more about this from some of the people that follow me, particularly Josh Denny, a lot of what has driven my thinking about this is our experience in the eMERGE network, because the eMERGE network has actually used electronic health records data to develop phenotypes and then do genomics, but is also, and in that context of discovery, but is also, I think, in a very exciting place where we're doing precision, personalized, genomic medicine kinds of activities in terms of putting information back into the electronic health record, creating clinical decision support that goes with that, and using that to actually provide information to patients and to use that in the provision of care. And I'm guessing Josh will talk a lot more about that. But I wanted to say that it was this context of the eMERGE network that's made me, driven a lot of my thinking as I was thinking about this. So there are sort of three approaches that Dan presented in the overview yesterday, and that have come up time and time again in our discussions about where the clinical information that we're going to use, where the electronic health records derived clinical information we're going to use might come from. So the first one is, we spent a lot of time yesterday talking about the cohort of cohorts. And we've heard things ranging from It's a great opportunity to its old way of thinking, and we should be cautious about limiting ourselves by the old way of thinking. But I think there's a middle ground. The middle ground is to think about what are the strengths. And I think the strengths are that we could think about the cohorts where we can go in and, in addition to the information they have, perhaps link with the information of their participants' electronic health records. Might require new consent or an additional consent, but that would merge two elements of data I think that would be especially valuable. They have the potential for active engagement, both of the scientists that were involved in collecting those cohorts, but also of the participants of those cohorts. And I think there's also the opportunity for wide scientific engagement because as we have a cohort of cohorts, the PIs of each of those cohorts is likely to want to stay engaged, and I think that's a real strength. The possible weaknesses are the potential for limited data elements and the status of consent. So what my job here is to think about that context and think about what the business case is. What kind of incentives do we need to apply in order to bring the cohort of cohorts together? So what are some of the potential barriers? And this is where I worry about the Debbie Downer role, but it's the loss of control of data. And I think while none of the, one of the lessons I think of the Genome Project is that people learned that they could submit their data directly as it came off the machine and still benefit from that. And I think that's a background that we want to constantly improve on as we think about patient care data. But the problem is that a lot of that patient care data is, at least by the institutions, thought of being owned as either by the cohort or by the institution. And so we're going to need to think about that as we design what this cohort looks like going forward, because there's going to be some nervousness about both the cohorts and I think about the institutions that I'll talk about in a minute. The next issue that I think is going to come up is the issue of sustainability. If we're using a cohort and that cohort has come to the end of its lifetime and now is sort of mature, how do we sustain that going forward? Because we're going to want to be able to go back to the participants and we're going to want to be able to go back to the people that created that cohort. And that might lead to reduced engagement by the investigators who established it, and that's definitely a negative. I think we want to make sure that they stay engaged. So what are the incentives to be a cohort to participate? Well, expanded data that adds value to your additional goals. If you had genome sequence, for example, on all of those participants, that would give you the opportunity to do exciting new stuff with your cohort. One of the things we learned in eMERGE is the idea of increased statistical power. Often sites by themselves don't have that sufficient power, and we've heard even in 1 million for many kinds of conditions we might be limited. So that's an opportunity. And then the opportunity, I think, for expanded recruitment. The second category we heard about were clinical providers, their ability to provide extracts of EHR data. What are the strengths here? Well, there's extensive and varied data. The data is real-world unselected data, so it's not subject to all the tightly defined inclusion and exclusion criteria that many cohort studies have. It is warty data. It's dirty data, but it's what we're going to encounter in the real world. And if we're going to think about an implementation piece to precision medicine, we really need to be able to deal with that warty, dirty, complicated data. One of the strengths of the clinical providers is since they have regular ongoing interactions with the participants, there's the opportunity to provide a fairly granular consenting mechanism if that makes sense. And one of the things that I think is a really exciting opportunity on the implementation side is this really has this group has an opportunity to move us forward in the area of thinking about how do we actually implement learning healthcare systems. How do we engage participants in that and create this really fantastic virtuous cycle where there's a study that informs clinical care, and the clinical care and its successes or a lack of successes inform studies that need to go forward. The weaknesses here are the data is a sparse matrix. You don't have the same amount of data on everybody. You've got varied data on lots of people. On the other hand, there's ways I think that we can think about how to deal with that. And then I think the other thing from the institutional perspective is it does require additional consenting, and we'll need to think about how to deal with that. So what's the business case for clinical providers? Well, the potential barriers are loss of control of the data again. And in the case of clinical providers who are at least at potential risk for liability for use of the data, there are going to be liability concerns that are going to need to be factored into how do we think about this. And one of the things that our experience at Emerge has driven us to think about a lot is that this also requires the active commitment of clinical IT operations to provide extracts of the data. And the clinical IT operations are currently very busy worried about things like meaningful use and making sure that their clinical systems are fully operational on a day-to-day basis. And the last thing they want is some group of researchers coming in and mucking around in their clinical IT systems and potentially the risks of that. What are the incentives for the clinical care providers? Well, that return of data is actually likely to benefit clinical care down the road. That's, I think, a real value. Potential marketing value. Those of us that come to DC on a regular basis can't help but hear ads on the TV that talk about people that are marketing the fact that they're doing precision medicine. Well, so I think a lot of opportunity for marketing value and distinguishing oneself in a clinical market is an interesting opportunity. Again, the opportunity for expanded recruitment in that site. And another interesting possibility that was mentioned earlier today is that this actually might align with new payment models for how we're going to support the clinical enterprise going forward. The third area were volunteers that are using blue button technology. And this is really exciting, and the session yesterday afternoon really energized me and actually made me think that maybe this is the one where the barriers and the incentives need to be, maybe are already pretty well addressed. The strengths are really engaged participants. There's a clear mandate from the community to participate and to actually use the data and do something important with it. And it also solves the ownership problem that the other two organizations have, because these are the people that really own the data and can say, yes, use my data. The weaknesses are, I think, blue button technology is not quite yet mature. That doesn't mean it can't become mature, but it will be something that we need to develop. And both a weakness, but probably an opportunity, is that it requires tools and method developments to fully utilize it. And I think we will actually be able to play an important role in creating those tools. So what's the business case for the blue button volunteers? Well, the potential barriers are the need to develop strong educational programs to help them think about how to use that blue button. Maybe it's as simple as pressing a button on an app on an iPhone, but my guess is it will take something more than that. The problem of uneven levels of participation amongst participants. That's not likely to be a problem only for the blue button volunteers, but maybe even less of a problem for them. One of the things I always worry about is study fatigue. If they're the active participants, are they really going to be anxious to get 2 texts a day, or are they going to want something somewhat less than that? And I think the complexity of data interpretation. A lot of people worry about, we give people a genome sequence back, but do we just give them the raw sequence? And then what are the obligations for us to actually help interpret that data? And I think that's a really important topic for discussion. The incentives? Well, the return of data may benefit clinical care. It's the opportunity to improve the future health of their family and their friends and their community. And I think what most of us that have worked in this space see is the altruistic motivations of our participants are one of the main drivers of the work that we do. And then, of course, their engagement as a full partner is a real benefit. So that raises a broad question that I want to pose out there, no answers, but we're going to need to discuss as we think about designing this cohort going forward. And that is the question of centralized versus federated organization. A centralized organization is typically perhaps more efficient, but it's potentially unwieldy. We also need to think about how to develop credit mechanisms for the people that contribute to that centralized mechanism. And because both in the academic world and for the organizations that are contributing, there are costs that are associated that we're going to need to think about. For the federated, it maximizes broad participation. It encourages local experts with domain knowledge, and it reduces the concern of loss of control. But it's also an organizational nightmare, potentially, for the people that establish a federated model. So I want to make sure that we're having a robust discussion about which approach this takes. So then what's next? Well, EHRs and the data they hold, I think, represent a critically important resource for this effort. And the good news is, for the most part, somebody else is paying for that resource and collecting the data. That's of a lot of value. It brings a lot of value to the table. We should explicitly consider the incentives and disincentives to participate for all the stakeholders. And I think by doing that up front, we'll be able to get it right, because if we don't take that into consideration, we risk very much getting it wrong. And then I would end by saying that we need to incorporate the planning for implementation, because many of the considerations for implementation will be critical as we think about the cohort and we think about the data that's available to them. So I'll stop there.